Welcome to Talking Meds on the Presqipp podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Ho, 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 and welcome to the Christmas edition of Talking Meds. I'm Jonathan Underhill, and I'm joined today by Dr Lucy Pollock. We're going to have this as a festive edition of the podcast today. And you will have heard Lucy and I talk lots about, within our series, Sensible Prescribing in Older People, about the importance of empowering patients and making sure that we take into account their views and expectations and what matters to them. So we thought we'd talk about drug holidays. And drug holidays are essentially where you can empower patients to start and stop medicines according to their circumstances. And it might be that during the festive period that there is the opportunity for people to start and stop medicines according to their lifestyle and what they're doing. It also happens that Presqipp have just produced a bulletin on medicine treatment breaks, otherwise known as drug holidays. So that's bulletin 358. Subscribers to Presqipp will be able to access that, and we'll put the link in the show notes. So, as I say, I'm joined by Lucy. How are you doing today, Lucy? Are you well?
I am very fine, and happy Christmas and a happy New Year to all our listeners. And everybody loves a holiday, so this is a good opportunity to talk about really good holidays from medicines, when we can use them, how we use them safely. As you say, Jonathan, how to give your power to your patients.
Fantastic. I think I also need to say that a geriatrician is for all year, not just for Christmas, isn't it, Lucy?
Yeah. We're here day in, day out for forever and ever. And there will be lots of people probably listening to this. They might be on their way to work on kind of New Year's Day, and the streets are empty, and they're wondering what to do with themselves. And I'm with you in spirit. We both are.
Very good. So tell us about drug holidays then, Lucy. How do they work?
Yeah, I love the theme of drug holidays. And actually, you watch your patients when you say, would you like a holiday from this drug? And you'll get a smile. And the way that I use these is when you've got something which is meant to be coping with symptoms. This isn't about your prognostic benefit drugs. This isn't about your aspirin or your statin or whatever. This is about a drug that is supposed to be helping some symptoms. But really often patients are not sure whether it really is making a difference or not. And at that point, the really sensible thing is say, well, why don't we try a holiday? We can do this safely. You can come off your medicine, but you can be in charge of whether you start it again, because you're the person who's getting symptoms, and you will know whether, after a certain amount of time, you'll know whether that was making a difference or not. So the kind of drugs where I use a drug holiday are classically the overactive bladder drugs. Loads of people are really not sure whether the medicine's working. And they're right to wonder. We know they work for 1 in 9 people. Are you the 1 in 9, or are you one of the 8 that's not getting any benefit? I use them for angina drugs. I use them for some analgesics. We might just briefly touch on carbocysteine for COPD, because you may not need to take that all the time. And so those are my big groups.
Okay, so it's the medicines that help with people's symptoms. So the things that people are bothered about are the symptoms, obviously,
yeah. And
using these medicines to treat symptoms can be a really, really good thing. But then when you don't have the symptoms, I guess it's a difficult question, isn't it, as to whether you stop with medicine or not. And as you said before, it's for those medicines perhaps that don't have as much prognostic value, i.e. they don't prevent really, really bad events happening to you, like hospitalization or having a heart attack or a stroke. So, and obviously when people stop medicines, there is that anxiety, isn't there, with that? Is it safe for me to do this? And what circumstances is it safe for me to do it? So what do you say to patients along those lines then?
Let's take the overactive bladder drugs for an example. So what people might be anxious about there is not necessarily safety, but dignity. And they think, oh, I really don't want to be wet. If somebody's really confident that the medicine is working, fine, they stay on it. But, you and I know that loads of times you'll say to a patient, do you think it really makes any difference? They've still got problems with continence. They're not sure whether it makes a difference. and they can't really remember, did it make a difference when I started it a couple of years ago? I'm not really sure. Often they're getting side effects. They will have that dry eye, dry mouth, constipation problem. And so there you really say, well, look, why don't we just do a trial of stopping it? And I get hold of the box and I write holiday in big letters on the box. And I will say to my patient, listen, try stopping it. And if you find your symptoms get worse, just go back on it. You don't need to do anything special. Keep the box, don't throw them away yet. Keep them for a month or two, and you decide when you get whether you need to restart it or not. How quickly might you know that? It really varies from one person to another. If they're very organised, I often suggest they keep a vague bladder diary, just a scale of 1 to 10. How bad are my waterworks today? Because again, it can be quite difficult to kind of remember, am I better this week than I was last week? So if you can just keep a little diary and look and see whether there's been a problem. And lots of people will come back and say, do you know, it wasn't making any difference. I'm glad I stopped it. If you found in a month or two that it isn't making any difference, you're no worse than you were, you can let your GP know to take it off your prescription list. If you still need it, you've got it. And that puts the patient in charge. And I love that they feel that they're in control of that situation. In the safety one for people with angina, that's a slightly different one, isn't it? Because nobody wants to have a horrible sweaty angina attack. But we also know that taking Nicorandil or a nitrate or ranolazine doesn't have any prognostic benefit. These are not drugs that are going to stop you having a heart attack. They may help with angina. And again, lots of people with frailty and older people, if you ask them about angina, they'll often say, I haven't had angina for ages. Do you find that, Jonathan?
Yeah, absolutely. And I guess it all depends on people's personal circumstances as well. So it might be that over Christmas and New Year, for example, you take it easy and you actually you're not doing the things that you would normally do, such as going for a walk or whatever. So you might not need your anginal tablets because you're sat in a chair and you're talking to your grandchildren or whatever along those times. So you don't get those anginal attacks and in effect. And I think the other thing that's just come across to me from that conversation there is that the importance of reassurance of people saying, it's very unlikely that anything really, really bad or serious is going to happen if you do this. Keep an eye on it. Make sure that you're monitoring your symptoms and all the rest of it. And then if they do come back, then please restart your medicines. But nothing bad is going to happen to you probably if you stop them.
Yeah, and for somebody who hasn't had an angina attack for a year or two, which is lots of my older patients who aren't really moving around anymore, they're very unlikely to develop new angina when they've come off the nitrate that they've been taking for years. And then you might also say, well, why rock the boat if they're stable? Why would you stop the medicine? Well, because it's a burden of a pill. You're taking something you don't need to take. Lots of people get postural hypotension, and drugs do have side effects. So that would be true of the nitrates. Ranolazine is a drug that sneaks into people's list as a sort of last attempt of controlling angina. We know it's frankly not a very good drug. Scotland won't even recommend it for use. It causes weakness commonly, or even very commonly. So a lot of people actually feel quite relieved to come off that drug, and they will often say, oh, I don't think my angina is any worse. Angina is complicated. Lots of people who get chest pain will find that it isn't actually angina anyway. So there are lots of people who can quite safely come off those tablets. If it's somebody who you're a bit more anxious about and they think, oh, I used to get angina, I don't get it now, and I think it may be the tablet that's helping, make sure they've got a GTN spray, make sure they keep their tablets. If they get an angina attack, rest, take your GTN spray and restart your routine angina tablets again. It's a completely, very reasonably safe thing to do. The COPD one is an interesting one. Carbocysteine, you all know it. It's a huge, flipping huge tablet. It's one of those ones that looks like a pessary, and you've got to take 2 of them 3 times a day. That's a big old tablet burden. Now, for some people, it's fantastic. It's loosening your phlegm, helping you clear your phlegm. But actually, if you're one of those people who gets the odd exacerbation of COPD with nasty sticky phlegm, but the rest of the time you haven't got a cough at all, well, why not take a holiday from the carbocysteine? Keep it in the cupboard, don't discontinue it completely. You've got it there. At the first sign of trouble, you get your winter cough, go back on it, because you want to be able to clear that phlegm and not develop a bigger exacerbation. But if you've got days and days all over the summer where you're not getting any cough, you're not producing phlegm, completely reasonable to take a holiday from the carbocisteine. Now, obviously, those are quite complicated, those instructions, so you might need to write those down. And be really clear about the fact that you are giving that person permission to control their own medication.
Yeah. I guess the other question that I often, as a pharmacist, get asked about is around Christmas time is it okay for me to have a drink of alcohol with some of the medicines that I'm taking? I mean, you must get asked that all the time. You've got an older person who perhaps is on analgesics, or they're on things for their bladder, and where the effects of alcohol can exacerbate some of the feelings of tiredness or drowsiness, and the last thing you want then is for that person to fall and have a fall and then damage themselves. So what do you say to patients in those circumstances?
Do you know, I had a history teacher years ago when I was a child who used to say, as the Spartans would say, everything in moderation, nothing in excess. Okay, and for most people, a little drink of something that you like is a very, very good idea. And yes, lots of drugs will come with labels saying avoid alcohol and so on. To be honest, a lot of patients know that they can drink safely a small amount. You know, who's going to stop you having your glass of sherry on Christmas Day? And so obviously you don't want to go on a bender, and older people can drink less, find they, even I do not have the tolerance for alcohol that I used to have. And we all know that as we get older. It's actually a really good way of explaining to medical students and to patients the effects of medications becoming more potent as you get older. You say, I bet you can't drink as much as you could when you were 18, and anybody will roll their eyes and say, tell me about it. It's alcohol's a drug, it has effects on your body, and those effects get more profound as you age. So be careful, but be sensible. I get very sad when people are told that they mustn't have another drink. I've got people who have been on their deathbed, and you say to the family, is there anything she'd like? And they say, oh, she'd love a gin and tonic. And you say, well, I've got one, and I keep one in the office for this very moment. And they say, oh, really? Is she allowed that? And you just think, oh, God, of course she is.
Yes.
So yeah, just being sensible. You have to be respectful if there's a history of real alcohol problems. So occasionally a family has kind of rolled their eyes and said, please don't let Dad get back on the whiskey, because that was a serious problem in the past. So just be a little bit cautious. But most of the time, a nice Christmas pint is a very nice thing to do.
Excellent, sound advice as always, Lucy. Just to finish off then, if anyone has been given a book token or other similar sort of, or is looking for an idea for books, there's two books that I'd really like to recommend. And Lucy's far too modest to want to talk about her own books, but Lucy's actually written two books. One, the first book was the book about getting older, wasn't it? And your second book came out in the summer, I think, called The Golden Rule: Lessons in Living from a Doctor of Aging. So I love both the books, and Lucy knows this, so I'm not just saying this because she's here. The thing I like about The Golden Rule is that she uses real life stories to tell, to look at how we can create a better society to help our older people. The storytelling in there is really, really wonderful. So, so that would be the first book. And the second book is my old colleague, Professor Neil Maskery, who many of the listeners will know. I worked with Neil for many years at National Prescribing Centre and at NICE, and he's written his memoirs, which is called Rebalancing Medicine. Again, a real
it's a lovely book. It really is a lovely book.
A really good read.
Good stories.
To talk about the history of the NHS and where we've come from, and importantly where we need to go to in the future. As he says at the end, the NHS healthcare is there's enormous complexity, and therefore there are no simple solutions. But in the face of complexity, some things are better than others. And also there are some great stories along the way as well. I think that's exactly right. There's no easy fix to this. Where Streetling and his team are trying really hard to come up with something that's going to fix the NHS. I'm really sorry, guys, you're never going to be able to fix the NHS, but there are some things we can do that can make it better. And that's exactly what we're seeing all the time. And books like this, I think, really help with getting people just to think about how we can make things better and how we can improve things for people.
I think exactly that, Jonathan. And it is all about the thing that really changes things is framing it around our patients, what their wishes are, what their hopes are, what their values are, those shared decision making, involving patients and their families in every service development, in every decision. That is where the wins are, doing things that add value to people's lives, not things that we're being driven to do by matrices and bureaucracy. It is about focusing on the individual, and that is where the benefits are. And those good care costs less than bad care. We can do it. It is going to make a difference.
Yeah, Lucy, it's interesting you talk about metrics and performance measures. My good friends at the All Apothecary podcast have been very kind in giving this podcast a lot of plugs to their listeners. So I thought I should return the compliment. They've done about 7 series of All Apothecary now. If you've not listened to it, please listen to it. It's really, really good, quite funny, light-hearted. Again, I'll put a link in the show notes to that. But episode 7.3, they had John Seddon on there. John Seddon wrote a book called Freedom from Command and Control, and it's really worthwhile listening to that podcast to get a sense of where we need to go with the NHS, and maybe less emphasis on the metrics and performance measures than the good quality care that we deliver to individuals. And of course, Lucy has also been a guest on the All Apothecary podcast, episode 4.1, talking about getting older with dignity. I think it's also worth saying, because it's Christmas, the All Apothecary have just done a yearly almanac as well. And one of the guests is me on that, alongside, and I'm known as the 5th apothecary, alongside the 4th apothecary, Claire Howard, who has also been a guest on here. We're nothing if we're not collaborative, eh? So thanks again, Lucy. Always absolutely wonderful to talk to you. I hope you have a fantastic Christmas and hopefully see you in the new year.
It is lovely to talk to you. I hope you have a very, very happy holiday season. And here's to, what are we, 2025? And
yes, indeed.
Very best wishes to all of our listeners and to you, Jonathan. And Happy New Year.
Yeah, all the best, guys. I'll certainly drink to what we just said there. So happy Christmas, Feliz Navidad, Happy New Year. We'll see you all in 2 weeks' time, where I'm going to be interviewing the aforementioned Professor Neil Maskery, who I worked with for many years at the National Prescribing Centre, and we'll be talking about his book, Rebalancing Medicine, and his ideas for how we can maybe not fix the NHS, but make things a bit better. See you in 2 weeks' time, guys. Bye.